Welcome to CFN's webinar series. Today we have More-2-Eat, Improving Nutrition Care in Hospital by Implementing Improved Practices for Detection, Treatment, and Monitoring of Malnutrition. Before we get started today, I'll just review some housekeeping items and some current CFN calls in process. We do have a question and answer period at the end of today's presentation. So if you could please submit your answers as we go along, and we'll try to get to as many as we can today. And if we do run out of time, our presenter Heather Keller will be happy to answer via email, which will be posted at the end of today's session. And Perry Kim, our manager of research, will facilitate the Q&A today. Just a reminder, the survey will pop up after your screen, and it's to provide CFN feedback and as well the presenter, and we will give that information back to Heather today. The webinar slides and the video will be available within 24 to 48 hours, and as you can see on the screen, that's exactly where it is on our website. We do have three webinars coming up. On Wednesday, November 8th, we have the Canadian Frailty Priority Setting Partnership. And on November 22nd, we have Introducing Electronic Quality of Life Assessment in Hospital Palliative Care. And on December 6th, we have Exploring the Preferences of Older Canadians Living with Frailty for Aspects of Patient Care. And we hope you can join us for those, and you can sign up anytime. We have a Catalyst grant competition in place right now, which addresses the polypharmacy and related medication issues in older Canadians living with frailty. If you haven't put in your intent to apply, this isn't for you, but for those that have, the applications are due November 13th by 5 p.m. Please visit our website. You'll see the URL there that will have more information for your application. We do have a new funding priority as a result of the patient priority setting. All the details have not been set yet, but please look to our website, and we will be communicating widely the information so people can apply. It will likely be between November and December when more details come out. We also have our HQP needs survey completed. It is now closed, and the CFN Education and Training Committee will be reviewing this at the meeting tomorrow as we try to continue to improve our CFN training program. So now we can begin today's presentation with Heather Keller. She is a nutritional epidemiologist and dietitian. She's a professor in the Department of Kinesiology at the University of Waterloo. She is the research chair in nutrition and aging with Schlegel University of Waterloo Research Institute for Aging. And her research interests include, of course, nutrition risk screening, assessment, and nutrition intervention for seniors in general and seniors with dementia in particular. So now over to you, Heather, to begin your presentation.
Great, thanks very much, Carol. And if we can just get this slide shared. Okay, there we are. Great. Okay, so we should be able to go. So thanks very much to CFN as well for hosting this important webinar. It's really a pleasure to be doing this at this time in this project, and to also chat about our future directions as we go forward. So I'm going to try to talk a little bit about today the gaps in malnutrition care and a lot of the work that's been done by the Canadian Malnutrition Task Force to identify those gaps and lead us forward with trying to make change. I'm going to specifically speak to the Integrated Nutrition Pathway for Acute Care, which we call INPAC, and how it was implemented in the More-2-Eat study, and that's where we'll focus our discussion today. Specifically, I want to talk about some of the key ingredients that helped us to successfully implement the INPAC in 5 hospitals, and some of the key behavior change techniques that were used by these hospitals to make change. Finally, we're going to talk a little bit about moving forward with the data that we've got, and give you a brief overview of the INPAC toolkit, which is already online and available for others to use. So first off, this is a huge team, the co-investigators, as you can see, and the collaborators on this slide. But in addition to that group, we had champions in each of 5 hospitals and research associates who were involved in data collection, and of course the trainees here at the University of Waterloo. So a very large team, and when you see the scope of the data collection that we have completed and now are in the process of analyzing fully, you'll see that we needed such a large team to make this effective and to actually happen. I just want to set the stage with why malnutrition. And malnutrition, for those of you that may not be aware, is actually comorbid or commonly overlaps with frailty. And this is not surprising because malnutrition affects every system in the body, and it leads to morbidity, affects wound healing, infections, complications, and convalescence. We know that older adults who are frail are also often malnourished, and so these things overlap, and it's important to address malnutrition then as a result to try to also address frailty. In the hospital system specifically, this slide is based on sort of that segment of the population. We know that malnutrition is linked to mortality in hospital, increased treatment requirements, length of stay, and also obviously healthcare costs. For the patient, it leads to impaired quality of life and increased suffering, and as I said as well, frailty. So the Canadian Malnutrition Task Force over the last several years has conducted a variety of research in this area to try to raise our awareness about the issues that need to be addressed. And this work is a flow through from that information. But just some key facts for you. In Canada, we did a study between 2010 and 2013 in 18 hospitals and identified a wide variety of things, but key results were that 45% of patients who stay more than 2 days in hospital in a medical or surgical bed are malnourished. As well, 75% of that malnutrition goes unnoticed. We know that malnutrition, when we compared it to people that were well nourished in hospital and controlling for all other sorts of things like disease and comorbidities, that malnutrition extended their hospital stay for up to 3 days. That cost just the acute care system in Canada $2 billion a year. So malnutrition is definitely costly to our healthcare system. Oops. I'm having a problem now moving my slides for some reason. Sorry about that. Hopefully it fixes now. In addition to that data on prevalence of malnutrition and its cost, as I said, we know that people are not necessarily eating as much as they should. About a third don't eat half of their tray during the first week of their admission, and we know that that also predicts their longer length of stay, regardless of their nutritional status. We know that patients experience a variety of organizational, mealtime, and eating environment barriers that impact that food intake. So there's things we need to do as a system to improve food intake. We also know, though, that food quality is also part of that picture, and that food quality influences the food intake in these patients in the CMTF study. Less than a quarter of patients actually saw a dietitian in our CMTF study, and as I said before, 3/4 of those were malnourished. 3/4 of malnourished do not see a dietitian. So something is broken in our system in that those people coming into hospital that are malnourished are not being identified by the staff who admit them or the staff who do workups or a variety of ways. They don't recognize that malnutrition is something that should be assessed and treated in hospital. We also know that most leave the hospital in the very same state as they entered, and about a fifth get worse. Once they're discharged from hospital, weight loss will occur in about 25%, and the majority of that weight loss is unintentional. And a big driver of that weight loss is poor appetite. If you're wondering about all these wonderful infographics we have on the slides here, those can be downloaded from the Canadian Malnutrition Task Force website. They're available for everybody to use. But they're lovely pictures that basically give us a good snapshot of the key information from that study. Although in the CMTS study we did not look specifically at treatment, we know from around the world that nutrition treatment works. So in the hospital, we know that mealtime management, eating assistance are proactive strategies to support food intake. Although the findings tend to be a bit mixed around the studies that have been done in this area, in general, they do seem to increase food intake. And I say the findings are a bit mixed because often implementing changes in care practices that are involving eating assistance can be very challenging to implement and sustain. Oral nutrition supplements, a lot of work has been done in this area, and a review of reviews actually identified that these supplements increase body weight, function, so thinking about frailty, for example, complications, and mortality. So nutritional status can be improved with these supplements. And finally, if we involve a dietitian in the counseling of patients with or without the use of those oral nutrition supplements, again, a Cochrane review demonstrated that this could increase body weight and improve nutritional status of patients. So we do know that treatment works. So just to summarize this a little bit before we get into the More-2-Eat study specifically, the prevalence of malnutrition for those who stay more than 2 days in a medical or surgical bed in Canada is about 45%. Nutritional status will deteriorate in hospital for some. Food intake less than 50% of the tray, and malnutrition are independent predictors of length of stay. Malnutrition is costly in human and financial terms, and we know that treatment can improve outcome. So how do we get that treatment happening? The response was the integrated nutrition pathway for acute care. The CMTF researchers got together with a variety of other stakeholders and thought about how could we actually make care better. We came up with this system or algorithm. I'll just go through it in detail on the next slide, or next 2 slides, I should say. So first off, it is an evidence-based algorithm for the detection, treatment, and monitoring of malnutrition amongst acute care medical and surgical patients. It is developed through consensus from leading Canadian experts, clinicians, and other stakeholders. We see it as a minimum standard for a hospital to provide good quality care. And this was also funded by TVN and CFN in 2014. In terms of key best practices for impact, on day 1 of admission to a hospital, medical and surgical bed specifically, all patients would be screened with 2 questions, the Canadian Nutrition Screening Tool, which is valid and reliable. These 2 questions actually don't require objective measurements, which means they're easy to do at admission. On day 1 or day 2, that patient who is identified to be at risk is triaged by using something called subjective global assessment, which is a standardized short assessment process that determines is the person severely, mildly, moderately, or not malnourished. That helps dietitians and others who are doing SGA to triage the next steps of care while in hospital. For those who are identified to be mildly or moderately malnourished, we recommended that they get advanced nutrition care strategies, basically anything that would support food intake in the hospital. This could be preferences, getting energy, high protein diets, supplements or snacks, all of those sorts of things that could promote the food intake of the hospital patient. For those that were severely malnourished, making sure they saw a dietitian for a full assessment to truly understand how to improve that food intake and nutritional status of the patient is needed. We call that specialized care. And for every patient, regardless of their nutritional status, we thought that standard care would be those things that would promote food intake. So for example, making sure a patient is sat up in bed, making sure that the meal tray is opened. Regardless of the nutritional status, every patient could be supported in that way. And then finally, monitoring those patients during their hospital stay, using food intake predominantly as a way to determine do they need more assistance or more assessment. Finally, discharge planning to make sure that there's a connection between the acute care setting and the home setting in terms of recovery with respect to nutrition. So that's the key best practices of impact. So we basically developed this algorithm and then realized, well, we have to make sure it's feasible. In came More-2-Eat. And basically the purpose of this study, again funded by the Canadian Frailty Network between 2015 and 2017, was to test and evaluate the implementation process of the integrated nutrition pathway for acute care in 5 diverse hospitals in 4 provinces, and also to develop a virtual toolkit that would support implementation of impact broadly beyond these sites. So today I'm going to be speaking with you about some of the key findings with changing the process of care in hospital and how successful More-2-Eat was with doing that in the 5 study sites. Key to changing practice is using a model like the knowledge to action cycle. And we relied on this, cycle as well as a variety of implementation science theories, frameworks, behavior change techniques, and thought as well about how we could actually sustain change. We didn't want to make a change that would then just go away after the project was done. We've tried to think about how can we make the integrated nutrition pathway for acute care the routine for the hospitals that were part of the study. And so relying on theory and some frameworks such as the KTA cycle were essential in our thinking and planning. In addition to the K2A cycle, we also heavily relied on the COM-B model for understanding how to make change. Most of us, I think that if we educate folks on what they should be doing, it should of course happen. But the reality is that's not the way it works. And so by using the COM-B model that gave us a sense of the different types of behavior change techniques you could use in a setting to change behavior, in this case of health professionals, to support that change, we were more successful. And so, for example, just to give you a sense of what COM-B stands for, C is for capability, O is for opportunity, and M is for motivation, with the idea that these change behavior. That's where the COM-B comes in. So capability, of course, education, building a skill, but also enablement in terms of changing the opportunity around the person. Opportunity, things like even environmental structuring, making it very easy to do the right thing, or modeling, creating a culture expectation for the behavior. Motivation, of course, in terms of persuasion and incentivization, so making it the good thing to do and the desirable behavior of your healthcare professionals. So we relied on these behavior change techniques, frameworks, and implementation science theories to help us do More-2-Eat. So this is a huge data collection, and we have submitted several papers, and some have been published already, and the key results that I'm presenting today to you have also been submitted and show the benefits of this More-2-Eat approach in terms of changing practice. But there's many further results to come, as you can see from this long list of data collection. I'll start actually at the bottom of the list because we're going to end with impact audit, which is the focus of this webinar today. So we wanted to track how implementation happened. And we had monthly teleconferences and scorecards to do that. And that's all been rolled up in terms of that learning in our impact implementation toolkit, which I'll show you where to go to on the website at the end of today. We also collected focus groups and interviews, and great thanks to Celia Lohr, my doctoral student, who was a CFN fellow during this data collection, to collect all that data. And that data helped us understand again how to make change and how to sustain that change in these settings. We also included a staff questionnaire, which again Celia was involved in terms of developing as well as testing out and using this data to help show change in attitudes, knowledge, and behavior by staff based on their self-report. We had a detailed patient data collection, this really focusing on frailty specifically, as well as patient-reported outcomes, and we're just in the midst of actually writing up that final paper for that work, showing that the changes put into place can actually change some of these patient-reported outcomes as well. And then finally, the impact audit. This is really where I want to spend our time today talking about. What we're trying to do is track on a monthly basis what happened in terms of those impact activities. So screening, SGA to triage patients, food monitoring, etc. It was a way of tracking basically the process that, the progress, I should say, of the sites towards making change. We fed that data back, of course, to the sites to help stimulate change and communicate with the team members about how they were doing. And so we're going to focus in on that impact piece. So impact was basically done 2 days, I should say, 2 days every month for the entire study. We had a developmental phase, which lasted about 2 months or so in terms of data collection time frames from September to December, depending on the time frame that the 5 sites conducted those audits. They did 4 audits each during that time frame. And then during the implementation phase, twice a month were audits done. And you can see the different periods that we have in the implementation phase, and then finally a sustainability phase. The implementation phase was 12 months, and this is where the sites were given the opportunity to try to change their practices towards the impact best practices. We'll go through what some of those are again in just a moment. So a lot of work to be done in a year, basically, to try to implement and make change and sustain change. And these impact audits were our way of tracking what needed to be changed as well as showing the progress in that change. You can see at the bottom of the slide here, this was collected in 5,000 patients in these 5 units in 5 hospitals. And so, as I said, it was one day that every patient that was on that unit that day, we went through their chart and tracked what had happened to them in terms of nutrition care activities, and did they match up with the IMPACT algorithm. So the IMPACT care activities that were implemented across the 5 sites. Nutrition screening admission was done in all sites using the CNST tool. SGA to triage patient was done in all sites. MedPass was done in all sites. And I'm going to focus on those first 2 at the top and show you that the ability to not only get those activities in place, but sustained over time as well after the implementation phase was completed. Most sites were also able to implement food intake monitoring and follow-up of low food intake, putting volunteers or some other supports around mealtime to support food intake. Weights being taken in admission, regular weights, making more food available between meals for the patients, and discharge planning. Some of the sites started to get into those activities during the 12 months. So just to focus in on screening and SGA, this is the 2 questions from the nutrition screening tool. I'll show you the actual questions in just a moment, but the top part of the algorithm here. So 2 quick questions that were reliable and valid, and we'd done that validation work with the CMTF study back in 2012, 2013. And here's what the 2 questions are. All these resources, by the way, are on the website as part of the nutrition IMPACT implementation toolkit, as well as other resources on CMTF. So if a patient identified these 2 items being yes, they were identified to be at risk, and they were then meant to be going through the triage process. So I just want to show you the screening uptake. And so on the left-hand side, you see at baseline, period 1 here was the baseline or developmental phase, and period 6 is the sustainability phase, and those phases in between 2 through 5 are the implementation, that the 12 months when all sites were working really hard to try to make change. And you can see a dramatic increase in screening success and screening uptake in the 5 sites, and that it was sustained as well during the sustainability phase. On the right-hand side, you see the variability by site. 3 of the, no, sorry, it was 3 of the sites actually had a bit of screening at baseline. 2 had done screening with another tool and were pretty good at it already, but were able to sustain it and actually get better because of CNST's ease of use. 1 site also did screening at baseline, but it was not a very easy to use tool. And you can see as a result, it was only being done about 20%. The dark line here is the average that is actually on the left-hand side figure. But 2 sites started from scratch, and you can see the dramatic increase that happened because of some key changes that they did in their system. For example, putting the screening tools on the nursing admission form. So it was an automatic thing that needed to be done. So what were the things that actually helped screening get into place? So of course, starting with education, so people are understanding why they're doing this, was important. But also making sure that the screening connected to the next step. Staff wanted to see the benefits of doing these 2 questions to the patients they were caring for. So we had to make sure there was a referral process that was built into the screening aspect for nursing staff. Working with staff to make sure that they were comfortable with the form and the process and tweaked it based on their recommendations was key. As I noted with that 1 site that had a dramatic upsweep in terms of its uptake, it was embedding the questions in the admission forms or in the electronic medical record that really made the change, making referral automatic as well, so that staff couldn't bypass it. They had to actually make an automatic referral with an EMR to the dietitian to do the next step. It was a key way to make it really easy to do the right thing, screening for all patients on admission. As well, using reminders and small group interactions to reinforce completion was a good way to embed the practice. And of course, through all of the implementation that we used in More-2-Eat, using those audits and feeding them back to staff to show how they were doing and celebrating the success of when they were doing a good job and reaching their goals on a monthly basis was a way to embed and routinize the practice. So let's now shift to the triaging with SGA. So SGA was a new practice for all 5 of the sites. And this was basically, as I said, the standardized practice of using key questions that focused on food intake, weight change, functional status of the person, and a physical exam to determine if they were malnourished or not. And they're classified into one of these three categories. All sites did not have SGA at baseline. So this meant doing work with the dietitians and others who want to be trained on SGA to develop a new skill base. But here, in showing our success, you can see dramatic success again with this implementation process. No sites were doing this baseline, but by the end of sustainability phase, it was being sustained at over 75% of the patients and reached a height of over 80% at the end of the implementation phase. Here again, you can see on the right-hand figure, the variability in sites, which obviously happens. And you're probably wondering, what is this downswing that happened around period 3 and 4? That's summer vacation. And so when dietitians were off on vacation and their replacements did not have SGA, they were not necessarily doing it as quickly or as readily for the patients that were part of the study. Just to show you how this worked in terms of triaging, as I indicated, the SGA was meant to identify those who really need to see a dietitian in terms of specialized nutrition care. So we wanted to see as many of the C patients and some of the B patients as well, potentially getting through to see a dietitian if they thought it was relevant. So this just shows you on this figure the process of going from screening through to seeing a dietitian and the success with that because of the SGA triage process. So here we have, that's one side, an example of 1 month. 85% of the patients on those impact audits had been screened, which is pretty good uptake. 34% were identified to be at nutrition risk of the 59. SGA was completed in 16 of those 20, and the other 4, it was referred but not yet completed. And of those who were B and C, it was 10 and 3 patients. Every one of those got to see the dietitian. So you can see the success of using that triaging process meant that a dietitian saw a patient much sooner, and it wasn't left to the discretion of team members who may or may not view the person as malnourished. So a huge success. So how do we get SGA implemented? Again, SGA hands-on training to build the comfort level of the nutrition staff. Mentoring and buddy system also worked very well in some of the sites, and we know, for example, that every one of the sites has moved beyond that single study unit to actually get SGA and screening throughout their hospitals already and using a buddy system to do that. As well, making sure that the triage process was in place so that dietitians knew exactly how to go about triaging in terms of the advanced care, especially what to do with those SGA-B patients who didn't need the specialized care of a dietitian. There would be an automatic way of referring them into some of those advanced care practices. And just to note, I don't have it on a slide here, but our impact audits showed as well that at baseline, 30% of patients were getting some type of advanced care practice. By the end of the implementation, it was 60% of patients. So a huge uptake in treatment as well because of the implementation of impact. Also slowly starting to use the SGA and slowly incorporate it into regular practice. We're now finding as well that folks say they're using it for every patient that they see because it is a way to get a good sense of what's going on with the patient overall and building rapport and identifying the needs of the patient. So we're seeing people using SGA in these hospitals even if they're not screening to get the referral going to the dietitian. And finally, building SGA into part of regular documentation and working through that process with the RDs so they feel really comfortable and tweaking that process with them. So all sites did that tailoring, that documentation piece in their own way. And this is why it became routine for them. This slide just shows you some of the diverse behavior change techniques used. I wanted to show it as a kind of a messy slide, but it basically shows you that education is not necessarily always the best way to get change happening. So the green line is environmental structuring. And when you think about the MedPass and the other advanced care activities, the SGA triaging, the screening putting in place, those were environmental restructuring often because we're changing a form or putting it on the EMR or making it really easy to change the referral form so it's really easy tick boxes for team members so that that referral can happen. Those were environmental structuring things. So it wasn't just education. Education is not enough, obviously. Celia also did a very nice study comparing the knowledge, attitude, and practice of staff at the beginning of the study, before implementation, and after the implementation process. And I just wanted to highlight one key finding for you, or a couple here on the slide. So out of the staff at these 5 sites, 70% noticed a positive change in what was happening in the care of their patients. And these staff were everything from physiotherapists through to nursing, through to doctors on that unit. So within a year, they had noticed a positive change. And when they were asked about what changes they wanted to see, felt involved in the process, and were supported to make change, they also had significantly higher knowledge, attitude, and practice questionnaires with respect to nutrition care practices. So what this tells us is that staff want to and need to be involved in the making of change process happen in a unit with respect to nutrition care. And so it's really important to do all those front end things that we did for research purposes as well, in terms of building rapport and building the staff engagement. So for example, having those focus groups that we did at the beginning of the study, we now realize that's an important part of implementation, regardless of using that data for research purposes. So building that rapport, building the involvement of staff throughout the implementation process is key. Sia also has published this very nice thematic analysis, trying to get us understanding of how to make change. What is it that's going to make change stick? And this is what the staff member said, this idea of building strong relationships within the hospital team, making sure you have a reason to change. And that's the idea of we need to know that nutrition care is not adequate and how to improve it. Involving the right people at the right time in that change process, embedding the change in the current practice, and then of course accounting for climate, which goes beyond the context. It's everything from the focus of the hospital at that point in time, the key drivers that are happening at a management and higher level, as well as in the unit level in terms of the things that are going on in that specific context of a unit. Those are understanding those and accounting for it and tailoring what you're doing to meet those ends, as well as the impact implementation, was what led to our success. So some key things that we've learned about sustainability and spread. Champions can't do this alone. Of course, a key point person is necessary, but you need a dedicated team. Something like impact is the entire team's effort with respect to making change. It's like hand washing. Everybody has to do it. And so we have to think about how to make it a common practice that everybody can take hold of. And so we found that having an implementation team was essential. That could be 2 or 3 key people that work with the champion, and of course bringing in key other individuals as needed over time with respect to key activities. All professionals have a role to play in improving nutrition care, from physician through to the food service worker who's delivering the trays. Everybody has a place to play in this process. As well, realize that context rules. Every one of the 5 sites did things slightly differently. They had to tailor the activities in their own way, using their own forms, using their own ways of educating their team members. So you can't package up too much of an intervention. You have to allow for tailoring that happens within making change in these sites. Reiterate again, education alone is not enough to truly institute change. You need a variety of behavior change techniques, and it takes time to do that. And finally, key, of course, is using data and feedback. It's key to stimulating team members to make change and to sustain that change. We were able to achieve this in 12 months in 5 hospitals. Not every hospital have the same capacity to make that kind of change in that time frame. So be realistic with yourself as well, and don't think that you're going to change everything overnight. Take it one step at a time to make those changes. We've wrapped up all of these learnings into the Impact Implementation Toolkit, which is at this website on the Canadian Malnutrition Task Force website. And so it's an interactive site. There's some videos from the champions you'll see that is very motivational and supports people to take up this initiative. And there's a large toolbox around each of the impact activities to support folks with trying to make change in their own area. There's PowerPoints that demonstrate the need for making change. There's examples of how to put CNST into your admission form, etc. So please go to that toolkit to think about how you might stimulate change in your own area. Just to let you know, we have a mountain of data from this study, and we've certainly analyzed the key the points that we wanted to already out of this work based on our funding requirements, but we have many more analyses to be done. And specifically, we've done some work around frailty indicators in this work. Tara McNichol, one of my master students in this study, collected data and analyzed the data around feasibility of doing frailty indicators in hospital, specifically hand grip strength and 5-meter walk, and the predictive ability of those two indicators to predict length of stay as well as quality of life of patients, and also to look at how these indicators are associated or not with malnutrition. And so those papers are coming out right now as well. We also have data on patient-reported outcomes, specifically with respect to food intake and barriers to food intake, and that study has been analyzed, and we're just in the process of writing it up and getting it out, as well as quality of life and how that changed because of the impact implementation in these 5 sites. And then finally, we have lots of data on healthcare utilization, specifically perceptions of new practice and how to incorporate into the workflow, such as the subject global assessment, for example, as well as looking at length of stay and its impact because of the implementation. In terms of our next steps for research, we're actually tweaking the impact itself, the algorithm, minor changes based on what happened in More-2-Eat. Essentially, we demonstrated what we wanted to. It truly is feasible and can be implemented and sustained. It just needs a little bit of tweaking to make it a little bit more applicable in a variety of settings. As well, we've applied for funding to do More-2-Eat Phase 2. And for those of you that are on the call that are in a hospital, if we get funding, we'll be sending out an expression of interest to hospitals to be one of the next cohort part of that study. And what we're trying to do in Phase 2 is demonstrate that impact core activities, specifically screening, SGA, and the implementation of MedPass in 5 new hospitals can be done without implementation funding. And we're going to be using the key behavior change activities that we used in the More-2-Eat Phase 1 study, using a registry for self-management and audit and giving feedback to sites. So rather than us doing it at the University of Waterloo, the sites will have the opportunity to put in their own data and get out their own report and use that data to support change with their team members, as well as having a community practice that online and monthly gets together and talks about change and how to make change and how to support each other with that. Finally, we're also doing some work with patient food experience. Myself and a researcher from the University of Guelph, we have OMAFRA funding, that's Ontario Ministry of Agriculture and Rural Affairs, to look at patient satisfaction with respect to food specifically in hospital. So those are to come. So in summary, I hope you've gotten a better realization today that malnutrition is certainly a prevalent and costly problem to our healthcare system and highly associated with frailty. It can be treated though, and processes of care to detect and treat malnutrition need to be improved. We've demonstrated with the More-2-Eat study that impact is a feasible algorithm. There are some costs and investment needed for implementation, but with those, we can improve care for patients in hospital in Canada. So with that, I'd like to acknowledge our source of funding and support, in-kind support as well. And thank you, and open up for questions.
Thank you, Heather. That was an excellent presentation and very informative. And we really appreciate you sharing your research work with us today. And so now we'll start the Q&A. There's quite a few questions, and some of them appear to be a little bit similar, so I'll try to group them together. In the M2E study, was the hospital food changed to encourage food intake, like for better taste?
Yeah, no, that's an excellent question. And no, again, think about a 1-year time frame, and we knew that screening and triage might be the most important things to get going with respect to identifying malnutrition. Food is a key change as well. Some of the sites had done some work a little bit before that, and some were still thinking about making changes with respect to food, but it wasn't part of the impact itself. It definitely is, though, a key area that needs to be improved in some hospitals.
Okay. Here's a good question, is how do we scale and spread this across Canada? And I'm not sure if it's ready yet, but
yeah. And so that was our main thinking with More-2-Eat Phase 1. We wanted to make sure that people, if they had the initiative and the capacity, that we would equip them with the Impact Implementation Toolkit. So that right now is readily available for folks on the CMTF website. I know anecdotally from talking to folks that some have started to try to implement screening, for example, because of that initiative. And so that's the first step. The second step, though, as we recognized with the More-2-Eat phase 1 study, is there really are two things that folks really wanted and need, I think, to support that scaling. This is community practice, so that they can talk to someone else who's trying to do this and get some feedback and some ideas and support. And so we're trying to build out with the More-2-Eat phase 2 project that we're hoping to get funded. And then secondly, a registry. Every site said the audits were essential. That data that I showed you today, having that to feed back to your sites is important. And most hospitals don't have the capacity to run those analyses every month on their own. And so building some sort of registry that automatically allows, once you've got the data entered, to print out beautiful graphics for you to show the trends, or what we call the run charts, to show how you're doing month to month, is essential. And so that's a key aspect that I think needs to happen.
Yeah, I think that's the only way you're going to have sustainable change. And those community of practices work so well. So again, you had said that some people were trying this. Is it just in Ontario or other provinces
No,
as well?
it's beyond. And in fact, we have translation happening in Australia and potentially in the UK, depending on funding. So one of our collaborators, if you noticed on one of the early slides, was from Australia. His name is Jack Bell. And he's done a little bit of implementation work with respect to hip fracture patients in a rehab ward in Australia. And I knew of his implementation efforts there and wanted to build on his expertise with our More-2-Eat study, invited him to be part of this project. He's now taken Impact and tailored it to the Australian context, because they do have screening in place already in Australia. What they needed help with was a triage piece using the subjective assessment, and how to find a better way to get folks seeing a dietitian. So what they had been doing in hospital there was screening goes directly to the dietitian for a full assessment, which meant that dietitians were often having a hard time meeting that demand. SGA gives the ability to triage and do a quick 10-minute standardized assessment that allows you to say, no, I don't need to do further assessment, but the patient needs X, Y, Z to make sure they're eating enough in hospital. That's a key piece. So we've seen it beyond Ontario for sure. Across Canada, I've heard of anecdotally, again, people trying to pick it up and make change. Of course, More-2-Eat was national as well. There were one site in Alberta, one in Saskatchewan, one in Manitoba, and 2 in Ontario. And so we're hoping with phase 2 that we'll have greater uptake from other provinces as well to be part of that study.
Oh, that sounds great. That's what our goal is to get this across Canada. So how do we prevent malnutrition from occurring in the first place? And what can ordinary citizens do at home when caring for older adults with or without frailty to monitor their nutritional status and to modify the nutrition? What kind of changes in nutrition are recommended for older adults?
That's a great question. Absolutely. So as I noted, with the CMTF work, we demonstrate that people lost weight after they were discharged from a hospital. And so malnutrition starts in the community, quite frankly. Some of it also starts in hospital because of what we don't do, like providing food that people want to eat, and also complications in hospital that may make people stay in bed, etc., and they become frail and not eating food. But in the community, what can families do? What can seniors themselves do? Watch their weight, first off. No one should be losing weight with age, especially if they're not trying to. And if they are losing weight, it should be done mindfully through a high-quality diet and exercise. Exercise is vital to maintaining muscle mass in older adults, even more so than younger adult populations. You actually have to move more to keep the muscle you have with age, because of the physiological processes that happen in the body that really make it hard to keep your muscle. So that's the first thing. Move as much as you can, exercise, resistance exercise preferably, and watch your weight to make sure you don't lose weight. Secondly, watch for poor appetite. It is a key issue for older adults. As soon as you start to have poor appetite of any extended period of time, such as a week, try to intervene on that and think about how it can be improved. Talk to your doctor. Is there something physiologically going on that could be leading to poor appetite? Often is lack of activity will also affect appetite, as you can imagine. But low appetite is a signal to family members and weight loss. It's something significant is going on, and that is potentially rolling into malnutrition. And so nutrition screening tools that are used in the community often also look at poor appetite, weight loss, specifically weight change, and then poor intake of a variety of foodstuffs. And so if you see appetite being poor, weight loss happening, get your older adult family member to a doctor and talk about how they can improve their nutrition. In the community, there's a variety of services that many older adults are hesitant to start or don't even know where to start with accessing. But if you have challenges, for example, with grocery shopping, there are services available for that. Transportation to the grocery store, for example. Meal programs where you can go and have a friendly chat with some older folks, play some cards, and have a great hot meal, or Meals on Wheels programs. And then finally, thinking about how to get energy and nutrient-dense food into the diet of an older adult. And so there's a variety of strategies that can be done. There's a variety of high-protein foods that can be accessed, and if required as well, oral nutrition supplements for those individuals who have very poor appetite. So all those are key strategies to support food intake. I think a key takeaway, though, Carol, is that we should never think of weight loss, getting weak, getting tired with age as normal. It is not.
Yes, that makes so much sense. And there are so many care providers who aren't on home care, who aren't in the hospital, that are looking after people and don't recognize the signs. And I see that, you know, you had said something about social opportunities are a good strategy, and sometimes these people are too sick. So it's really good to have some kind of tool that everybody's aware of. And I don't know where you're at in terms of this is in a hospital setting, and what happens in the community, and is it different all across the provinces in terms of if they're on home care? Is there any screening being done?
That's a great question as well. And so I think the key thing, the power of our healthcare system is it is provincial, and it's also a challenge because it is disparate across the country. So for example, in Ontario, we have family health teams. And if you are fortunate to be part of a family health team, there's a dietitian automatically in that family health team. The question is how to get a patient to that dietitian who's an older adult who's frail. We don't have screening in place in family health teams. There's a few that have started. There's some in Hamilton, for example, in Sudbury. They've started some nutrition risk screening in Falls clinics as well. So it is starting, but it's not taken full hold. And I think we need to shift policy as well as make it the norm that this is a part of primary care practice, that if we are going to address older adults in terms of their health and keeping them well, nutrition screening as well as frailty screening have to happen in primary care. Other hot pockets of some really good activities. New Brunswick has got some really great activities with their hospital to home or hospital in the home sort of practices that are consistent with like home care that we'd see in other provinces, but it is varied. And I know, again, from the Ontario perspective, it is very hard to get a dietitian in home care to see a patient. And it's typically for one visit only. And it often be for those people that are on artificial feeding or for coming home from hospital, or often young children, for example, that are getting home care. So the frail older adult who is the big user of home care services is often not getting access to these services that they need, and screening is a key step to getting them there. There are screening tools available. I created one called Screen2. It's available for anybody to use. It's self-administered or interview-administered, just not require objective measures, so really easy to implement in the home without doing objective measures. There are some other tools also available, mini nutrition assessment, etc. So there are these tools available. We need to get it implemented. That's a key strategy. So I think there are some hot spots of good practice. We need to then build on that and get those practices translated across Canada.
That's great, Heather. And you know, when you just said about the Screen2 tools, where can you access them, and is there an awareness of where you can access them by the community itself?
Yeah, that's an excellent question. No, there's not. And maybe CFN can actually, we can push out some things, because I think your audience is a bit broader than mine typically is. But Nutra-E screen is actually part of Eat Right Ontario, but anybody can do it around the world. It is the screen tool basically on an electronic platform on the internet. And that site, if you just Google Nutra eScreen, but I can certainly give this information to CFN that they can push out in other ways as well. You go in as an older adult, you fill out the questionnaire, and you get personalized messages for yourself about where you're doing well and where you can improve. That's already there and available now. For those older adults who need to do it on paper, for example, or it needs to be done in a doctor's office and we need primary care providers to pick up that tool, Flintbox. If you just do a Google again on Flintbox and look for screen and spell it as seniors in the community risk evaluation for eating and nutrition, you'll upcome the site. All the materials are there for free download, including training materials as well as ideas about how to do the referral process in your system. And so all of that is readily available for folks to be using. And if CFN and others wanted to push that out, that'd be great.
Yeah, I think that would be great, because obviously we need to build some awareness out there of where to go and what's a really good site to go. And if they hear it from, you know, some of the healthcare system people, then they will go there. And I'll end with one final question. I think we're getting close to running out of time. And we've discussed it here at CFN. Is there nutritional guidelines for people living with frailty, either internationally or in Canada? Like, do they exist as of now?
No, they don't. And in fact, guidelines even for hospital don't. Outside of INPAC, there's some guidelines around how to care for people, but guidelines around how to promote nutrition beyond INPAC, like the food, for example, we don't even have that for hospitals in Canada. And so one of the working groups from the Canadian Malnutrition Task Force is trying to work towards those ends with respect to building what we call standard of care around food in hospital, right? So I think there's a lot of work to be done with respect to raising awareness, building a guideline around frailty specifically and nutrition, and moving the agenda forward broadly across all sectors of care.
Yeah, I think that guideline and maybe even building it into some kind of accreditation process might give that a little bit more attention that it deserves. Yeah.
Absolutely. And so with the now having the results of More-2-Eat, we now have the evidence, at least for the accreditation piece in hospital, but also the evidence from the CMTS study says that community is where malnutrition starts. And there was actually a Stats Canada survey that was done in 2008, and they did follow up with the patients just recently and published that result, showing that nutrition risk using the Screen 2 tool that I've developed in the community is predictive of hospitalization and death. So we need to be using that evidence to, as you say, move the policy drivers with respect to accreditation. And so More-2-Eat shows now that we can do this. It is truly feasible. It is doable within our system, and we need to push the benchmarks that everybody's doing. And that's where a standard needs to come into play.
Yeah, totally agree. So Heather, before we leave today's webinar, I just want to give you an opportunity to see if you have any final thoughts to share today. I know we've gone through a lot of questions, so you might have answered most of them.
I think you did answer my big questions, Carol, but I think I'd leave it with everybody that food truly is medicine, especially for the frail older adult. And there's many ways that we can intervene, and we're not. And a lot of it is we know what to do. We don't have the right people in the right place doing those things, and that's the trick. And so we have dietitians equipped in the community and in acute care to provide the needs of patients. We're not getting people to them, and we need to put screening into place across the sectors to do that. So thank you very much for this opportunity to speak with everyone.
Oh, well, Heather, we really appreciate your presentation and for answering all these questions today. It was excellent. And I thank everyone today for signing up and actually attending this webinar, because I think this is a very important area, and it's something that we can all do together to create awareness. So again, thanks to everyone. And if you would please provide some feedback with that short pop-up survey, and you can leave some comments for Heather and for CFN for improving going forward. So I think that kind of completes today's session, and I think we have right on your screen now, if you did have any further questions, that Heather has her email on the screen now, and you can contact her directly. So again, thanks for everyone attending today, and thanks, Heather. Have a great day, and that concludes our webinar.